back in Denmark, back in Copenhagen, this is my client. This is a client, diabetic client from Denmark. He's a male. And when I saw this, I thought, oh no, there must be a wound down there. There must be an ulcer around down there. But after cutting off the skin, it looks like this. And the rest of it looks like this. So there was no ulcer, thank God for that. But what do you do here with this kind of cracking skin, hard skin? The hard skin is, you can file on that for hours, for days, and you will never get rid of it. You have to put a knife on it. But after you take away this, you can instruct the patients by doing some peeling. You have a lot of perfect stuff down here, peeling for the body with salt or something like scrubs. And encourage the patient to use that, because that scrub takes away the cracking and the dry skin, and there's oil in it as well. I use that for all my patients. All my patients, when they're finished with the treatment, they get this scrub. And it's really good. You can see it's the same foot, and after the scrub and after the cream, it looks like this. And this is easy. This can be done. Everybody can do that, also at home. So that would be a very good way to encourage the people to take care of their feet. It feels nice, it's soft. This is also, from my clinic, it's also a male, and as you can see, he has compression on there. So he's not wearing orthopedic shoes, he's wearing normal shoes. So it can be two things. The shoes that he has gone in has made it, or it can be the compression bind that is also occurs to that. But what I always do is I take away the skin. Go off it goes. Because this one, if you let it stay, this skin is dead. It's already been off the body. And if you let it stay, it will grow to the skin again, but it will grow like it's like this. It will not straighten out, it will just be like this. So off it goes, so you can heal from the bottom. And you can see it takes it off, cut it here, this one it is, and I cut it off, and then you have it cleaned, and then you just put dressing on to absorb and to make it dry. And this man will come to me every second day for a week, so I check out how does it look. This is also a patient of mine. He's 90. He's a diabetic and he had it for 40 years. And he still doesn't know that what I tell him is how it's going to be. He still walks around barefoot. He still walks around in sandals. And his walking is not very good, so he bumps into things all the time, and that's why his toes looks like this. As you can see, he's also have compression on, and that's because that's because he has an ulcer, but further up the leg, and that's not my area. That is the doctor's or the hospital's area. We are allowed to treat ulcers until Wagner 2, and that's it. Then it's off they go to the hospital or to the doctors. And we also have to inform the hospital and the doctor what we do. We have a system that is connected to the health system in Denmark, and we write there and tell them what we do. He is also a risk for. Now, this one is also a patient of mine. She's a female, as you can see. She has nail polish on. She's also a diabetic. The problem with the women is that they still want to wear the high heels, tight shoes, look nice. But sometimes it gives some problem. And as you can see, she has a hard skin here. Underneath it, there's a cone. It's very deep. Usually I do like this. I take away the hard skin, I take off the corn, and then I make a facility for offloading it. This one is in silicone. It's amazing good, really good. You cannot, even if how much you press on it, you cannot feel the skin. You cannot go in and touch the skin. So she will get something like this, and she will wear it, and then she will come back in a week, and I will take if there's anything left inside, because when you cut away the hard skin, and you can see the corn goes into the skin. When you take away the hard skin and you take what you can out of the corn, the skin will raise, and you can take a little bit more of the corn, and that's why they come in a week after. So we'll be sure that everything is gone. This is a patient. I was a podiatrist in Gentofte Hospital for a year, and this is a patient here. And I don't know why it's like this. It wasn't when we made it, but anyway. But this is to show you that what we also do is we try to help people with malignance. And he has that. He has a pes cavus, as you can see, and this is a very big one. And he also has neuropathy. He also has atrophy of the skin. So he has a foot that is in a risk of develop ulcers. So we prevent for that to happen. So we will send him to an orthopedic, and we will send him to have insoles. This is a light box. Do you know that? Do you know anything? Nobody knows? No. This is a very, very good tool to teach the patients to look after its feet, because suddenly they can see their feet underneath. We use it a lot to tell people you have something wrong with your feet. You're not standing right. There's a wrong pressure on your feet. You have to do something about it. And then you can see I can't remember, I don't think no, it's not, because this is from my clinic. But as you can see, the spots that is more yellow-green, that is where the pressure is, and here is nothing. So this one looks like he also have a pes cavus. Because pes cavus...
I think, Lone, that's a wonderful thing, because one can know the foot pressures and the areas, those are under high pressure, by a very inexpensive way of having the light and the... Correct. Lone, what I was suggesting that we have, we didn't take the entire 30 minutes, he has taken only 20 minutes. So we will be winding up at 3:35 or 3:40. So we will now, if you want to demonstrate the dressings that you have brought, the offloading.
I have a few pictures left. Can I just...
Oh yes, please go through them.
Good.
Yeah, we have just a presentation by Dr.Sreekumar on the vascular assessment and referral.
But I can just do in the end, the treatment then, so you can have your time.
Will you demonstrate those things you have brought? We are interested in seeing your offloading and your. You can go through quickly.
Yeah.
Sure.
This is just to show you how I make insoles. Oh. Some of them. Took some of the foam with that I use, but this is some of it. It's made in the hands. This is a female diabetic, and she is born with a drop foot. And that's just to tell you that we also have our fight with the orthopedian in Denmark. As you can see, her shoes are not wide enough, and that's why she's getting that clavy all the time on her toe. And this is also a part of our job, to talk to them to make sure that the shoes that they're provided is the one that fits their feet. And as you can see, there is a lot. I wanted to talk to you about some shoes, because you have we have a challenge down here with shoes, because a lot of you wear sandals and not closed shoes, and you don't have many shoes that had a stiff back heel, and that is very important if you want to make the stabilized foot being in that position you want it to. I took some sandals, and I will show you what I mean. This is my clinic in Copenhagen. You should have something like that in your hospital clinic. and you should have a podiatrist. So make an education down here. Thank you very much. This was a cake and it tastes delicious. So thank you very much for listening.
Thank you, Lone. Give a big hand for the whole presentation. We have got about 10 minutes. Can you demonstrate something you want to demonstrate?
Not in 10 minutes.
Okay. Then you take a longer time. Please sit down. Now, dear friends, we had a wonderful feast of pictures and beautifully discussed regarding the feet, possibly the neuropathic feet, with a ulcer on the pressure area which was not known. She showed also the kern on the side of the little toe. That toe, that is possibly something like which has to be excised, and you can see. And also she showed the various other aspects like foot ulcer, including the changes in the nails. She showed from the simple skin thickening to skin which needs peeling of the skin to make it smooth. And she showed a variety of ulcers. And of course, she didn't forget to show us about the footwear. That is very important, and I think that's enough. I'll just ask you a few questions for the benefit of our audience. What is the mechanism you usually do the offloading with what? Can I have a mic here, another mic? Offloading you do with a contact casting or do special shoes?
Like this, yes. That depends on the patient. If it sends off to the orthopedic, I'm out of it. I can come with my meaning. I can come with to tell them I think you should do this and this and this. But I do a lot of insults for people that in the normal shoes, and that I decide what I want to do.
I think what she's referring to is a very important way of giving the insoles in your existing shoe and making holes or making the offloading during the insole itself, where the ulcer is there. That's a beautiful way of taking the diabetic foot. Now, do you also use any of those customized shoes, like half shoes or rocker bottom shoes? Do you use any of those?
No.
No?
I make them all of them myself.
Fantastic. So that brings down the cost very, very drastically, because buying these shoes, Dacro, you know what's having Dacro in your country, and other companies' shoes are very, 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 very expensive.
You can make them very cheap. You can learn it. You're so good at your hands down here, so you can learn it.
Yeah.
It's no problem.
Yeah. We also do manufacture some shoes. I'm not going into details because of interest of time, but I must tell you the shoes you manufacture are usually MCR shoes. Okay. MCR. And people do not like MCR because it is sometimes gives a connotation associated with Hansen's. Yeah. So that is why we do not use that.
That's also something we have a very big discussion of in Denmark, because when we have patients, we said you have to buy shoes that your foot can fit into. Then people come and say, but I will not wear shoes that is made in where they build ships, because that's not fitting for what I'm doing in my job. And I have to say that even if there were tight shoes, the insoles will help. It's better without. So you have to do it, even if it's not the shoes is not totally as it should be.
Yeah, I think that's a very important point, because the shoe and the wearing a proper shoe, avoiding what you rightly said, avoiding the slippers, especially the Hawaii slippers, where your toes are under too much of pressure, is a great. If you just tell your patients, Bala, Pandalam, you do it all the time. When you say just avoid the sandals, avoid the Hawaii chappals, where your foot pressures are totally wrong, this is a great help. Now, having said that, what's his meaning? That majority of the people will benefit from a large, roomy shoe, and they want tight fitting, so they will have tight fitting. But inside that ordinarily worn shoes, not customized, she can do the insole designing, and that will help them. Am I correct?
Yeah.
And that will help them. I think that's a good concept. That is out of 3 or 4 concepts they're giving. Is a very good concept that you have got. Now, I guess that you have a lot of ischemic ulcers. like the 90-year-old lady you showed, and maybe.
Yes.
So, what's your approach for those ischemic ulcers?
Yeah, but they at the first time they go to the
Doctors,
hospitals.
Hospitals.
We are seeing them further down the line.
Yeah.
But it's important to make offloadings in soles where it is, and that can be all around on the foot.
Yeah. Because as we'll come in a minute, the issues relation to the ischemic ulcer is a different type of business, and dents know what they are supposed to do. They know better what they are not supposed to do. So that's why she said she handles Wagner stage 1 and Wagner stage 2. If it is Wagner stage 3 or stage 4, or you can have the corresponding classification of textures, corresponding classification, it will go to somebody else. And that's a very good thing. So you cannot go wrong. But you see the jobs that she does in the first 2 stages are great. Now at this point, I'll request Suresh, my dear friend, people who checked in late, I must introduce Suresh is a phenomenal endovascular surgeon and a vascular surgeon from the city of Trivandrum. He is a surgeon, he has got his fellowship in the vascular surgery, and he is also the secretary of society and done a lot of work. He is going to tell us, Suresh, shall I say that we'll initially have about 10 minutes, then I can come back to you. We'll have 10 minutes that Jyoti has put these clocks everywhere to make us conscious. You are not conscious, I am conscious. So this is in 10 minutes about how to assess the diabetic foot, the ischemic foot, and when to refer. Over to Suresh. Yeah, please. And Dr. Geeta is here. Today the renal diabetic foot became a big problem. Am I correct, Dr. Geeta? After dialysis, because of the pressure they develop, and also because of the vascular disease associated, Manisha wrote about the cardiorenal syndromes. There is also today the renal foot syndrome. But because of renal disease, they develop ischemic foot ulcers. So I think you will touch upon that.
Thank you, Professor Das, for the nice words. Good evening to all. Dr. Lone, dear friends, I congratulate Dr. Jyoti for bringing up the scenario of medicine in Trivandrum to international levels, and thanking for the rare chance for me to present a paper. It's quite important to any practicing physician in diabetes. We have many techniques in surgery, both endovascular and vascular. I have a few slides, but I will not go into details about it. One or two messages I like to convey to you. One thing is, I'll come to it later. So I'm not here to demonstrate the techniques of vascular surgery, but the importance of vascular interventions for diabetic foot. This is a very early picture. So there's no confusion regarding the incidence of vascular disease in diabetes foot. There are many studies, mostly came from the West, but now we have the studies in the East also. So it's confirmed. No doubt about it. We don't have to go for it. And of course, we agree that vascular disease in diabetic foot has a poor prognosis. That's our myth. We believe in it. But latest studies have clearly shows it's not acceptable, it's not true. It may be some exaggerated process, but the outcome is equal or better with diabetics than non-diabetics. We have many myths. It's a diffuse disease. Of course, it affects coronaries, renals, cerebrals, everywhere it affects. But any vasculitis, any vascular disease is a diffuse disease, not only diabetic people. Of course, a distal disease, but again that's challengeable because foot vessels are classically spared in diabetic foot rather than non-diabetic. High morbidity and mortality, but it's not due to diabetes, but due to other conditions. And of course, higher amputation rates are there in diabetes. So these myths are often challenged. So the question is whether we treat them or not. And our treatment, will it benefit the patient? And is it technically feasible to treat them, or do we have any outcome advantage? Yes, we have outcome advantage. It is proven beyond doubt. The advantages we achieved over years are good knowledge of anatomy, technical skills, importance of endovascular technology, better management of diabetes thanks to you people, management of complications, of course, better surgeons. The facts are, to be answered, is the disease process same, is the pattern same, the response same, and is the treatment same. So the question is, it is the same process of in a non-diabetic man or lady, but only thing is the pace of atherosclerosis is accelerated in diabetic people. It has same risk factors. If he smokes, increases. If he has renal disease, it increases, and its distribution is also almost same as a non-diabetic. The only importance is it has a sparing of food vessels. Food vessels are classically spared in diabetic food, but it is affected in non-diabetic people. That's importance, and we can do interventions depending on this. And always we say this aortic segment is classically involved in a non-diabetic people, but is spared in diabetes. But it's an outdated principle. Both affects all areas with some little difference in the incidence. So if we go to the early experience when we start vascular practice, most of them were non-diabetics, not due to the particular disease pattern, but due to less number of diabetics among us and higher number of smokers. That interventions were technically easier, but the tragic thing was there were high incidence of amputations. So the question is, how do we assess this patient? That's the importance of conducting these programs. Though we have lot of armamentarium, the importance lies in only one factor: clinical assessment. The clinical assessment, that's the most important part. It forms 70 to 75% of the analysis of a diabetic foot. That includes history, whether peripheral pulse is present or not, whether the limb is viable or not. That's very important. Whether the limb is, if we save the limb, is functionally viable, and more than that, what are the comorbidities the patient has? That includes kidney, heart, and carotids. In fact, if you look at the pulse, if you test the foot without a gloved finger, and if you do a complete assessment of the patient, that forms 50 to 60% of the clinical evaluation. Then only comes other investigations. Again, if you have BPI apparatus and a stethoscope, if you assess the ABPI, angle brachial pressure index, that forms the, I will say, 90% of investigations, unless you are going for some interventions. At this point, we can classify these patients into two categories: patient requiring vascular interventions or not. And if they need a vascular intervention, then only you go for other sorts of investigation, Doppler or angiography. But you can treat 90% of patients. Especially Dr.Lone has showed patients for Wagner 1 and 2. These two investigations, that is clinical assessment, your hand, your brain, will form the complete investigations. Then the question is, when to intervene? Depending on these two factors, you can classify these two patients into two categories. One is claudicants, second is critical limb ischemics. Claudicants are those group of patients without any tissue loss, without any ischemic changes. Patient can sleep comfortably in the night, but the patient develops pain in any of his muscle groups. Most important, the below in the segment, the muscle groups, they are from the claudicants. The question is whether to intervene or not. Till date, we don't have any consensus to intervene in the claudicant group. On the other side, the critical limb ischemia mostly forms the Wagner's grade 3 and grade 4. They include patients with rest pain for more than 2 weeks. They can't sleep comfortably. They have a tissue loss, a minor loss or a major loss, or they have a non-viable limb. So that blend of claudicants, they have intact vessels, they have a pedal arch, they have a good vessel runoff, and they don't have any comorbidities, and the importance is 25% of them at least will go in for a critical limb ischemia, which require an emergency interventions. So still I say, if the patient affords to do it, and if it's functionally limiting the patient's life, better go for intervention of claudicants. On the other side, the critical limb ischemia, there is tissue loss, patient in critical state, patient may be having other comorbidities, whether it will restrict our mode of interventions, like if the renal parameters are low, are poor, we cannot do an angiogram, we cannot do an angioplasty, we may go for open surgeries, and of course, with all the complications together, they may have the financial constraints. So our aim of intervention is preserve the tissues, preserve the bipedal gait, preserve the functional limb, not to have a cosmetically beautiful with a fully viable limb with all 5 digits. That's not the aim of treating a diabetic foot, particularly in the Wagner stage 3 and stage 4. So this is a leg staging system. The importance of it, if they score the limb depending on the score system, and depending on the score, if the score is 0 to 9, always go for open surgery. If the score is 10 to 19 for intravascular, and if it is more than 19 at the time of admission, better go for no interventions to save that foot, but to go for early amputations to save the life. That's the importance of it. So the management is basically lifestyle changes, medical management, surgical options, endovascular options, and hybrid procedure. Thus, sir, do I proceed or do I stop it rather than going for management part? Okay, good. The lifestyle changes, you are experts than me regarding this because you are treating the patients, more patients than me. That includes smoking, cessation of smoking, regular walking exercise. But one word I should say is, the walking exercise, when you say that should be monitored, that definitely there's a change in the pattern. You ask the patient to record the distance they walk every day. And always insist that patient should stop smoking. Unless the patient stops smoking, there is no meaning in doing intervention and other risk factors, diabetes, etc. The medical treatment has plenty, but that may be the only drug which have a definite effect is lastosol, which is having a definite limb saving effect. The surgical management are mainly the endarterectomy, femur bypass, profunoplasties, or you can use different grafts. I'm not going to details of it. There's various bypasses. You can bypass any vessel to any vessel if they have a 15 centimeter normal vessel distal to that affected part. One point is pedal bypass procedures. It may be the most important the era of limb saving procedures, that is bypass procedures beyond the knee joint. That reduce amputation by 50% as per many studies, and primary patterns are better and limb salvage rate is very good. The advantages are you have to have a very small superficial target arteries. We can do surgeries with very little mobility even. The only thing is you have to do it before the infection is very much advanced. In this patient, the patient was referred to me, but till the infection reaches at this point, but only vessel possible is the posterior vessel, almost 5 or 6 centimeter close to the infected part, but still we have to go for intervention at this point. So here the question is, early evaluation is the must. So the endovascular part, you have diagnostic angiograms, you have conventional DSAs or CT angiograms, MR angiograms, and all the three options have problems with the renal parameter. So if the renal complications are there, we are restricted at this point. And maybe the only option available to them is carbon dioxide angiogram or a very good radiologist doing an Doppler ultrasound. We have angioplasty and stent placement or subminimal angioplasties. Advantage interventions are they have less mobility, possibly in all patients with an average general condition. It's a primary choice in many patients because of the advantage you achieved on the technical side, and stenting is mostly a Baylor procedure. So these are the certain angioplasties we can do. Angioplasty even at foot level, that's the advantage of with new techniques. That is, when the patient's ulcer is in the just above the calcaneal part, we can do this other concept called subbilium angioplasty, which is pioneered by Aman Bode, an Indian born, Gujarati born Indian settled in the UK. So why I'm here is,
I think three important issues. Number one, that diabetic ischemic foot is not rare. Am I correct? They are quite common today, and with the longevity and with diabetic renal dialysis, with cardiovascular disease, they occur almost quite common. In fact, we have evidences when do ankle brachial ratio, those who have the ABI less than 60%, they invariably have CAD and have severe perivascular disease. The second point is said that we have in our hands today to diagnose this ischemia very effectively. You have got laser Doppler, you have got Doppler, but a simple handheld ankle brachial index machine costing about 8,000 will give you a lot of information. It can be a mild ischemia when it is 0.9, it can be moderate ischemia 0.8, or when 0.6 and 0.5 or below, it can be CLI, critical limb ischemia. And third issue, she said that today our surgeons like Sri are absolutely equipped with the know-how, with the skills of the hand and the head to do the intervention to produce revascularization. like coronary revascularization. It has become routine, and this revascularization and the old things like diabetic vascular disease is below the knee. Bala, you remember we discussed, and it is multi-vessel. It is very bad. You cannot do anastomosis. Those days are gone, and they do stenting, they do the intervention, the end-to-end anastomosis, and the results, believe me, are fantastic. At this point, I will request Lone to kindly demonstrate. You can come to the front here.
As I said before, we haven't any patients, but I have a new friend here, and she said yes to make it. She has a problem. She has an ingrown toenail, and I will make a brace. I can't have any water. I can't have any towels. It's not providable right now, but I will do it, and you can see how it is, and it's effective. What I do first is I look down in the side of the nails to see how the nail is. How deep is it? How deep can I go? And then I just clean it a little bit. We don't have anything to clean with. This is one thing you have to say to your patients. Don't cut your nails down into the side. Because if you do like this, you cannot cut them straight, so you will leave a little piece of a nail, and when it grows out, it goes into the skin, and you cut again, and then you start an ingrown toenails. So always straight ahead. If you have some corners here, take a file instead and file them. Don't cut them. I'm sorry? No, we have to look nice. No.
Suresh, you are voted out.
You can put nail polish over the brace.
Yeah, they have antiseptic properties also.
Now I'm just cleaning around the nails, the side of the nail, to see how it looks. And I can see on this side, you cut some nail off. And there's a lot of hard skin in here. Doesn't it hurt when you go? Oh yeah, you said you can't have tight shoes on. That hurts. Take pictures of what you do. Take pictures of the feet that you see, so you can see what you do has an effect. That's also encourages the patients, but it's also encourages you to see, okay, this is really good, this I'm doing, or it tells you, I have to do it different. Take pictures, save them. I'm going to United States to teach them to do brace. This is perfect. You will see what's underneath there. Now it's gonna get hurt, I can feel that. There's a scissor downstairs in a toilet bag with flowers on. Can somebody bring them to me? Because this one can't be opened.
Yeah, I think that's signal, but you can take 1 minute more.
Thank you very much.
Otherwise,
that's a very quick treatment.
Take our guest to Copenhagen, nails done, and send her back in the next flight.
Yeah, I can do that. Yes, this is hard skin, and there's a corn here as well. No wonder it hurts. And sometimes under the hard skin and under the corn, there would be a hematome, because it's been a pressure for a very, very long time, and that's how our skin react on that. We do like this, okay? And put it here, and then we see which size is worse. This is this one. So we will put the circle here nearest this side. And you have to watch out that the legs in this one doesn't get too long, because then it will go, oh my God. I'm under pressure. When I press it a little down, is it still okay?
Give a big hand for Lone. Dear friends, please join me in thanking Dr. Sreekumar for the wonderful presentation. And I should say again, saying that the fight against diabetic foot is going to continue, and we'll win the battle. Thank you very much. Thank you very much.